Great, thank you. And I think I have 1 minute left. Is that how much time do I? No, seriously, how much time do I have? Session ends at 9:30. 11 minutes. Okay, thanks. I'll be fast. I want to first thank Paul Seegers for use of the XCAT Panem, and Bruno Deman and his team for the use of the CAT-SIM, and of course also the patients who participated in the clinical trials I'll be talking about. So the motivation here is that we still need more effective therapies for cancer. As you know, these all require phase 3 clinical trials before they can be moved into patient care. Standard of care CT, which just means do whatever, is used quite regularly in double-blinded, large, expensive phase 3 studies, which are typically multi-center, as a final step before submission to FDA. One of the things that's changing is that we're looking at more targeted therapies, which means it's harder to find the cohorts. So they're going to be smaller studies and they're more expensive as well. So there is a potential for quantitative imaging biomarkers to try to make the clinical trials more efficient and informative. But there is a gap, as we all know, between ideas for quantitative imaging biomarkers and translation to practice. This is true for clinical trials and clinical practice. However, clinical trials provides a good motivator to see if we can make them more efficient. And if we're looking at artificial intelligence-based quantitative imaging biomarkers, there's an even bigger gap, and it's kind of illustrated by this slide here. So this community, this is us on the left. You know, if we build it, it's going to get used. The clinical trial community is on the right, and they think, well, we're doing okay. And really, both groups are wrong. You know, if we build it, we're not going to come. They are not going to come and use our methods. And the clinical trials community, you know, is not going to take advantage of improved methods unless it's really demonstrated to them that it's going to help them in some way. So this is where the potential role of what is being called virtual imaging clinical trials, sometimes just called virtual clinical trials, where we can simulate the whole clinical trial. And this would provide us knowledge about the distributions of what's the sensitivity, specificity of anything that we're proposing. And here I'm talking about quantitative imaging biomarkers, but this could apply to more to alternative reconstruction methods, denoising, you name it. But they would also provide a rigorous methodology for evaluation. So you could present to somebody, say, look, if you use this approach, we can reduce the variance on your results, for example. A virtual imaging clinical trial is essentially a large simulation, but I think it's defined more that it's really a chain series that covers the entire sequence, starting with population models, models of disease, and therapy effects. And by models, I mean probability distribution functions. You say, okay, here's how it can change, and here's how often it happens. Those would then be fed into imaging scenarios where we're using physics forward models of scanners, reconstruction protocols, things like that. And then the third step is the image analysis. So what exactly is being done to the image? And then finally, we'll have an error model. A more concrete illustration is given here that we'll be using later. And just for terminology, I'm not calling this a virtual imaging clinical trial, although some people do with justification or virtual clinical trial. I'm calling this a virtual imaging pipeline. So on the top is kind of the flow chart. We start off with descriptions of the patient habitus. We talk about tumor model variations. This is then driving in our case, the XCAT Phantom. This is then fed into CAT-SIM, which will take in models of the scanner and the acquisition process. And then noise will be added, the quantum noise or other effects. Then it's reconstructed. And then we're going to do the analysis on the image, many images, thousands of images. And then from that, we'll derive an error model. And some graphical illustrations are at the bottom. So just for example, the very bottom left plot is the true tumor volume, just for example. And there's a probability distribution shown by the curve there. And we could just pick one value, if you can see it at the very bottom with the dashed vertical line, which is V1. So that's the volume one. It goes through this process of simulation, the forward modeling, the reconstruction, the analysis. And at the end, by some method, we end up with our estimate of the model. And we end up with an error model, which is the probability distribution of the estimated tumor volume for this particular original image volume. So this would change for different initial input image volumes. So this is what we call the pipeline. Now, to put this into an actual clinical trial, we have to think about it from a clinical trialist viewpoint, which is different from, at least from where I started on this. So they don't even think about imaging. They just think about the numbers at the end that they get, such as, say, tumor size, for example. So there's many types of trials. This one that we used here is fairly common. You have a population that's selected on some basis. Typically, they're known to have a certain kind of cancer. They're randomized into two arms, a control arm and a treatment arm. The control arm's on the top here. And then we could imagine first a baseline scan, and then they'll get some treatment, which I forgot to show here. And then they'll have a follow-up CT scan. In each of these four cases, we would rerun the virtual imaging pipeline to get our randomized distribution, trying to summarize over the entire population of all the variables. And then from that, we'll get the robustness, information on the study power, type 1 error, and potentially requirements on our quantitative imaging biomarker. Oh, and I should mention, often, not always, but often the goal of a study is to start with a null hypothesis that there's no difference between the two arms, and then the statisticians at the end are trying to prove that that's not true. They're trying to disprove the null hypothesis, because that means that there was really a measurable effect. And if they get it wrong, that's the type 2 error rate. So we took a clinical trial. This one was called the Velour clinical trial, and this was published, I think, the final results in 2016. This one, just for interest sake, looked at, there was an anti-angiogenic agent that was added to the standard of care chemotherapy that was infused, called FOLFIRI. And this is for patients with metastatic colorectal cancer. And I was trying to find the cost of the study. I couldn't this one, but for sure it was well over $20 million was spent on this one study. And it could have been 100 million. I mean, that's not out of the question. In this case, there was 1,200 patients randomized almost exactly 50-50 between the two arms. And then standard of care CT imaging was done every 6 weeks until disease progression. And then the tumor, in this case, was just RECIST criteria, which means measuring the tumor long axis size. And by the way, standard of care means you go to a center and you just say, I want a CT scan. You don't tell them anything else. And you hope you get a CT scan. Sometimes you get an MRI scan back. It gives you an idea of the quality control. And it's not, to be fair, you're trying to get as many images as possible. And in this case, the studies were collected at 221 centers around the world, mostly US, but worldwide. So there were at least 221 different CT scanners involved, probably more, and everybody was doing their own protocol. And the images were read locally. At the end of this, it's shown in the publication that this drug, which was expensive, increased the overall survival by about 1.5 months. And this is pretty typical for a new cancer therapy. I mean, it's just hard. Specifically to quantitative measurements, they showed that the RECIST response rate, in this case defined as a 30% or greater decrease in diameter, increased from 11 to 20%. And that was the conclusions of the study. What we did then is dig through all the data that we, fortunately, because of my co-authors with the something called the Volpac set, we could dig through the data. Here's just a few of the statistics. So the top left is the histogram of the tumor diameter at baseline. The top right is the histogram of the pixel sizes used in the CT reconstructions. The bottom right is the MAS of the scans. For some reason, I don't know why, some of them were just unknown. although we had the DICOM images. And the bottom left is the slice thickness for velour, the dark blue bars. There's 4 other trials included in this particular data. So this is what was used to inform the probabilities of the model. And then for the CT imaging simulations, we couldn't possibly simulate all the CT scanners in that are manufactured and out there. So for a reasonable attempt, we hope, we took CAT-SIM, which is well suited for GE classes of systems, and we varied everything we possibly could within reason. So we varied MAS, KVP, spectral filtration, slice thickness, the reconstruction kernel. We varied the patient habitus. And I'm not sure in translation, unfortunately, you'd see where the 2 circles are, you'd see a really nice cross-sectional image through the lungs with you can see some samples down below that have been magnified. Tumor shape, size, location was varied, and then for every possible combination, we did 20 independent noisy realizations. And in this case, we just estimated tumor volume with a simple thresholding and using dilation and region filling. And we ended up with 2,500 lesions that were analyzed. And the final result of just this part was that it's a bit of a busy slide, but in summary, the overall bias of the results was 2%, which is not bad. The overall coefficient of variation of the tumor volume was about 15%. And this is consistent with some publications by phantom studies and patient studies in the literature, and I'm happy to share those with people afterwards. So that gave us our measurement error going into the virtual imaging pipeline. Then for the patient tumor size distribution, we had to model the therapy effects. On the left is from the velour data, and the bottom axis is the tumor size from the baseline scan, and the vertical axis is the difference between the baseline and the first follow-up scan. And we ended up modeling this as a correlated log normal distribution, which is not unusual in the biostatistics literature, I gather. And we got reasonably good agreement for our model. And we plugged that into the virtual imaging clinical trial. This is my second to last slide. So as a result of all this, what we did for the trial is the therapy effect, because we're just making up a therapy, we're just saying, okay, what's going to happen? And we talked about mean size decreases of 5 to 20%, but that was also a random variable because some patients' tumors shrink, some don't, some grow. We varied the number of patients from 50 to 400. We varied the coefficient of variation of the measurement error from 0 to 40%. So our 15% was in there. We set the type 1 error rate to 5%. So any one trial, any one run that had a p-value of greater than 0.05, we just rejected that. Which is a typical, I gather. And then for every possible combination of parameters, we did 1,000 simulations to reduce the standard error in our estimates. And on the right, what you see are the estimated study powers presented a couple different ways. So the top one, we have a fixed effect size of 10%. So we're saying on average, the tumor shrank by 10%. And then we looked at the impact of the number of patients from 50 to 400, as well as the variability of our volume measurement in this particular case, and the study power. And a study power of 80% is considered reasonable in clinical trials. So you can see that actually, if for 15% coefficient of variation halfway between the 10 and 20%, above 100 patients, say the 200 and 400, is certainly getting us a study power of above 80%, which would be pretty reasonable. And there's an alternative way of looking at it down below where we fix the number of patients, but that was at 100. So these were the kind of results we could get. So for this, here's my last slide. So our summary from this approach was that the velour study, at least in terms of the tumor size measurements, the so-called objective response rate, was certainly almost certainly sufficiently powered. And you could say, well, what did you actually show here then, Paul? That everybody's doing their work. Actually, though, what our results indicate is that it was significantly overpowered. In other words, They didn't necessarily need to do 1,200 patients. And in clinical trials, one of the big motivations is you do as few patients as possible because of the safety effects. So that's one argument. But the caveat is, the driving result was not just tumor result, it's overall survival rate, as I mentioned, which did increase. And we're not considering that here. I just want to be clear. The key point, though, is that this is building a framework so that as new methods are developed, we can put these into the virtual imaging pipelines and try to get a sense for overall how much is this going to help as a motivation for adoption in practice. And I think I said that, just I rephrased that a little bit in the last point. It's basically the same thing. Just the last thing is that as we use more and more AI-based methods, and to my mind at least, there's more and more uncertainty about what's really going on, this would potentially provide a framework for evaluation and hopefully adoption for the ones that are shown to be useful. Thank you for your attention.
Dr. Kinahan, very, very interesting work, and thank you, very much needed in this field. So my understanding is, one question, is that for new drugs, is it acceptable to just look at size change, or do they require, in terms of, say, an FDA approval, or do you need to go overall survival? And how do we go from image change to physiology side to go to overall survival?
Thanks, Srini. That's a very important question. Basically, pharma and the oncologists that are driving the trials really just care first and foremost about overall survival or progression-free survival rates. Those are the two driving things. But they almost always use size change by resistive CT. That's just a very common thing. And since they're using it, our thinking is that, well, if we can show that you're going to get a more accurate measurement in terms of either bias or reduced variance, that they will adopt these measures. Now, what that won't necessarily what that will do is change the study design. Of course, the therapy itself is going to determine what's going to happen to the patients, but you could then have a trial design where you're not underpowered and not overpowered. Based on the imaging biomarker aspect, at least. So it's more that this is, I think, or another way to put it, this is a lever that we can use for adoption in clinical trials, which then would hopefully lead to adoption in clinical practice. Aspirational.
Hey, Paul, just a quick question. Really great talk there. You probably mentioned, but how do you simulate the changes from the pre to the post CT scan, like the tumor changes?
Oh, we change the overall volume by a percentage, and the whole object shrinks or grows by a random amount.
Okay, how will that mimic the real situation, especially before the trial started? Will you get that kind of information?
Will you get a what, sorry?
Will you get that information about how much volume changes before the trials?
So I think if I understand your question, so if it's a new therapy, we don't know what's going to happen, obviously. So we can't say, what's going to happen. It would be wonderful if we could. But what we can say is, well, if you're going to measure a change, we can give you the error bars on the change. That's really what this is driving at. It's just for something to be called a quantitative imaging biomarker, there should be error bars on it. And this is doing that, but it looks at the impact over the full spectrum of application.
Okay, thank you so much for the brilliant talk. Let's thank the speaker again.